Hi everyone. So as promised, this is week 1 for the NEET PG 2025 and also for the FMG exam. The courses and the questions are more of very similar now. So there's not much of the difference. So it will help both the candidates. This is week 1 and we have started with obstetric emergencies, and today the first topic we have taken for this week is shoulder dystocia. In this video, we'll see the detail of shoulder dystocia. Okay, so what is shoulder dystocia? Very important definition. It was asked in the FMG exam. What is the definition? If the head has come out but the body does not follow even after 1 minute. So you have to know this definition, very important, that if after delivery of the head the body is not coming out even after 1 minute, that is shoulder dystocia. And why does that happen? Basically, the cause of shoulder dystocia is impingement of the anterior shoulder. This is a more common cause. So impingement of anterior shoulder behind pubic symphysis is the cause of shoulder dystocia. In some cases, yes, posterior shoulder also get impinged. It also gets impacted behind the sacral promontory, but it is a less common cause. So we know the definition, which we have to remember. We know which shoulder is impacted. It is the anterior shoulder. What are the predisposing factors? So shoulder dystocia is something which has very high mortality and morbidity with respect to the baby. So if we can predict it, if we somehow can prevent it, it will be great. So what are the predisposing factors? Anything that will increase the size of the baby, that can predispose to shoulder dystocia. So if the baby is bigger in size, the head generally tends to come out because of molding, but the shoulder gets stuck. So one of the predisposing risk factor is the maternal obesity. Mothers who are obese tend to have obese babies, tend to have macrosomic babies. That is one risk factor. Second, multiparity. So if you have seen your grandmothers or maybe great grandmothers, those who used to have multiple kids, if you'll ask them, you'll realize that as the number of kids increase, the size of kid increases. The difference between first kid and last kid is substantial in the weight, and the last kid is generally heavier. So as the number of deliveries keep on increasing, the weight of the baby you are delivering, it keeps on increasing. So a grand multiparous baby has a higher chance of shoulder dystocia because there are chances that she will be delivering a heavier baby compared to a lady who is primipara, who is delivering for the first time. So multiparity is another risk factor. Then diabetes. Remember, चाहे वो gestational diabetes हो, gestational diabetes means the diabetes which developed during the pregnancy, या वो pre-diabetic हो, mother was diabetic already. Both of them increase the chances of macrosomia. Please forget it that pre-diabetics में IUGR होता है. यार pre-diabetics में जब IUGR होता है babies में, it is a very late presentation. It happens in those pre-diabetics, in those chronic diabetics जिनको vascular pathology भी होगी, renal pathology भी होगी. In them the IUGR might happen. As such, both GDM and pre-diabetes, what do they cause in baby? Both of them increase the size of baby. So never think that pre-diabetes will cause IUGR. It can cause IUGR if the patient is in a very severe stage of diabetes. But the main manifestation is macrosomia, that too deposition of fat on the shoulders. So diabetes and GDM are a very big risk factor for shoulder dystocia. Okay? Postterm. Whenever pregnancy goes beyond 40 weeks, two things happen. Whenever the baby is beyond 40, so postterm is 42. I'm sorry. So whenever it is more than 42 weeks, two things happen. Those two things are the amniotic fluid decrease and the weight of the baby increase. That is why delivering a postterm baby is difficult, because baby tends to gain weight and the fluid decrease. Right? So all these factors increase the size of the baby, and hence they are the risk factor for shoulder dystocia. Right? Okay, you don't need to remember everything by mnemonic. Don't make a mnemonic for that. Just use the common sense that whatever will increase the size of baby will increase the chance of shoulder dystocia. Right? Okay. So certain things can be asked, that can we predict and can we prevent shoulder dystocia? First of all, yes, these are the risk factors, but predicting it is little difficult during the labor. So what we read in the last slide was the risk factors that can increase the chance of shoulder dystocia. But can we predict when shoulder dystocia is about to happen? During the labor, is there anything which can indicate that shoulder dystocia is bound to happen in this patient? Yes, when there is prolonged second stage. So cervix has been fully dilated, but after cervical full dilatation, the baby should deliver within 3 hours in a primipara and within 2 hours in a multipara. Right? This is the definition of second stage. So prolonged second stage of labor, if that is happening, that is a very big predictor that head might come out, but the shoulder will get stuck. And many times in prolonged second stage, what do? We apply instrument. So instrumental delivery, if it is a difficult instrumental delivery, remember there are very high chances that shoulder dystocia might happen because of your pull, head will come out, shoulder will get stuck. So these two are the predicting factors during the labor. Okay. Is there anything by which we can prevent shoulder dystocia? Yes, if we can prevent these difficult deliveries, we can prevent shoulder dystocia. So the prevention that we have available is elective LSCS. So whenever we see a baby whose weight is more than 5 kg, the elective LSCS is advised by ACOG. So whenever baby is more than 5 kg, by doing elective LSCS, we can prevent shoulder dystocia. In pre-diabetes, since we know in pre-diabetes and GDM, the fat is primarily deposited on the shoulder. So there, the weight threshold is 4.5. So in a diabetic woman or in a pre-diabetic or a GDM woman, if the baby weight is 4.5, do a cesarean. In a non-diabetic woman, weight of baby is more than 5 kg, do the cesarean. So this is the only prevention that we have with us to prevent shoulder dystocia. Okay, so you got the definition, you got the risk factors, you got the prevention and prediction. Now we come to the most frequently asked thing, and that is the management of shoulder dystocias. What to do when the shoulder dystocia has happened? So there are two types of maneuvers, maternal maneuvers and fetal maneuvers. Obviously, maternal maneuvers means you manipulate the mother, you manipulate the positions of mother, and fetal maneuver means you also call them internal maneuvers, because to manipulate the fetus, you have to go inside the vagina. So they are also called internal maneuvers. Doing the maternal maneuvers is easy. So first of all, always when the shoulder dystocia is diagnosed, you do the maternal maneuvers first. So as soon as you have seen that shoulder dystocia has happened, you have seen that head has come out, shoulder is not coming out. It is also called as turtle neck sign. Just like a turtle. You have seen a turtle? Not in real maybe, but in the videos, isn't it? In the images. In turtles, what happens? Just the head is outside, right? The rest of the body is inside the shell. So it is also called turtle neck sign when we can only see the head and not the whole body. So what will be your first step? First step is always gentle traction, axial traction. So when you see head has come out, shoulders are stuck, first step is gentle traction with maternal effort. You ask mother to push. You don't give fundus. You ask mother to push and you do a gentle traction, and that has to be axial. Axial means in the axis of baby. It should never be a lateral traction. Lateral traction matlab either the baby head is above or below the axial line. So lateral traction is not given. Why? There is something here, some very important structure here that will get disrupted. Brachial plexus. It will lead to brachial plexus injury. So axial traction is the first step. When with our gentle axial traction baby has not come out, now we are sure it is shoulder dystocia. Thoda to effort pehle denge na. Now we call for help. So first thing before going for any maneuvers is obviously call for help. You will be needing a lot of people now. You will be needing anesthetist, pediatrician, sisters for putting up a record, people for arranging for OT. You need a lot of people now. So you ask for help. Then you straighten up the bed. अभी तक mother कैसे होती है? Mother is in this position, no? जो head end होता है वो थोड़ा सा raise होता है, like this. So you just put it down. You straighten up the bed. Because now a lot of maneuvers have to be done. You straighten up the bed. Okay? For all the maneuvers. You bring the patient to the edge of the table. She should be edge of the table. The hips should be little hanging out of the table. So you bring the patient to the edge of table. Right? Now you start your maneuvers. So what are the maneuvers now? Right? So you Call for help, straighten the bed and bring her to the edge of the table. The first maneuver that you do is McRoberts and suprapubic pressure both. So everywhere McRoberts and suprapubic pressure are mentioned together, right? But still, if you are asked which one is done prior, McRoberts is always done, can be considered to be done prior to suprapubic, right? So you do McRoberts and suprapubic. What do you do in McRoberts? Let me erase this first. You flex the thigh, flex and abduct the thigh of the patient. That is the McRoberts. And the sister who is doing McRoberts of one leg will apply the suprapubic pressure. That is why they are named together. तभी इन्हें साथ में बोलते हैं, McRoberts and suprapubic, because the same assistant can do both of these maneuvers. But if you are given the option, I am telling you, choose McRoberts first. So when you abduct and flex the thighs, what will happen? This, can you see this image? So when you are, this is the thigh. When you have flexed this thigh, what has happened? First of all, this promontory has get flattened. It will get flattened. And it has, the pelvis has rotated kyphlically. It has rotated towards the patient's head. Since it has rotated towards the patient's head and the sacrum has become little flat, it creates more space in the inlet. The shoulder is still in the inlet, isn't it? Shoulder is stuck behind pubic symphysis. It has not crossed the pubic symphysis. ये अगर आपका pelvis है, this is the pubic symphysis, shoulder is stuck behind pubic symphysis. It means वो अभी inlet के अंदर भी नहीं आया है. Head has come out, but it has not even entered the inlet. So what do you do when you flex the thigh? The sacrum gets flattened and the pelvis rotates towards the maternal head. It creates more space in the inlet and the shoulder will come out. Along with that, you will ask the assistant to give suprapubic pressure. Remember, there is one assistant standing on the right side, one assistant standing on the left side. Who will give suprapubic pressure? देखो, अगर if this is the anterior shoulder and it is stuck, suprapubic pressure से क्या करते हैं? You put pressure on this part, on the posterior aspect of the anterior shoulder. जो anterior shoulder है, उसकी posterior aspect पे pressure देना होता है, so that this bisacromial diameter is reduced, so that ये कम हो जाए. So the sister who is facing the occiput, जहाँ पे baby का occiput है, ठीक है, where the baby's occiput is, that's where the place जहाँ पे anterior shoulder stuck है. So this sister who is facing the baby's occiput will put pressure on the shoulder so that this biacromial diameter is reduced. Right? Okay? So you have to give pressure on the posterior aspect of anterior shoulder to reduce the biacromial diameter. ठीक है? So McRoberts and suprapubic pressure. These are the first two maneuvers. After that, another maternal maneuver is Gaskin maneuver. If this is also not helping, these two are not helping, Gaskin is all four position. You ask the mother to lie down like this in an all four position. So when mother lies like this, it is said that under gravity, the shoulder will come out. Since mother will be on IV tubings, she is in labor, turning the mother down is it's little impractical. So Gaskin maneuver is not a very preferred maneuver. So generally, when the McRoberts and suprapubic pressure both have failed, we straight away switch to the internal maneuvers. Right? So what did we do? We called for help, straighten the bed, pull the patient to the edge of the bed. Then immediately we applied an axial traction. We try to pull it with a gentle traction. It's not coming out. We give suprapubic pressure and McRoberts. Baby not coming out. We can go straight away to the internal maneuvers. Okay, some prefer Gaskin maneuver also. Gaskin is all four position of the mother. Internal maneuvers might need episiotomy. So here you will consider, not always necessary, you will consider the patient for episiotomy before doing the internal maneuvers, because you have to insert your hand inside the vagina. So first internal maneuver is that anterior shoulder is so stuck, you will go behind the posterior shoulder, okay, and try to bring it out on the face and try to pull it out. So you try to pull out the posterior shoulder here. You go behind the dorsal area of the posterior shoulder, go towards this area, bring it out by rubbing it on the face of the baby, you will bring it out. So bringing the posterior shoulder out is the first thing. 90% of patients are successfully delivered after applying suprapubic, McRoberts and posterior shoulder sweeping. 90% of them deliver. 10% of them don't deliver. So what do you go for? You go for rotational maneuvers. Now you want to rotate. So where I told you the shoulders are stuck behind the pubic symphysis. They are above the pubic symphysis. So they are still at the inlet. वो अभी भी inlet पे ही हैं, वो अभी inlet को cross भी नहीं किए हैं. So here the shoulder is stuck. We know in inlet oblique diameter is larger compared to AP diameter, and transverse diameter is even more larger, isn't it? So what do we try to do? We try to rotate the shoulders now into a larger diameter. So there are two maneuvers. One is Rubin's maneuver. Remember, it is Rubin's 2 maneuver. अब Rubin's 2 है तो Rubin's 1 भी होगा. Rubin's 1 किसे कहते हैं? Suprapubic pressure को some places they call it Rubin 1 maneuver, the suprapubic pressure. Rotational maneuvers is Rubin 2 maneuver. What do we do in Rubin's 2 maneuver? We apply pressure. So that's what we are doing in Wood's corkscrew and Rubin's. So Rubin's 2 में हम क्या करते हैं? That, can you see, this is pubic symphysis. So this is anterior. So this part is anterior obviously, and this is posterior. It is clear? So anterior shoulder पे we apply the pressure on the dorsal aspect. Of anterior shoulder we apply pressure on the dorsal aspect. Again, what are we trying to do? वही चीज जो हम suprapubic में कर रहे थे, जो हम ऊपर से abdominally कर रहे थे, वो we are trying to do internally. We are applying to put pressure here so that this biacromial diameter, this diameter is reduced. So we are trying to rotate it by not much, just 30 degrees. So we are trying to rotate the shoulder by 30 degrees and try to simultaneously reduce this diameter. That is Rubin's 2 maneuver. If that doesn't help us, what do? We keep our finger here. One finger is on the anterior shoulder. We insert another hand and then we apply pressure on the posterior shoulder, and that to the anterior aspect. अब ventral aspect पे pressure लगाएंगे. So from one finger we are applying pressure here, from one finger we are applying pressure here. Now we are trying to rotate using both the hands. That is Wood's corkscrew. So Rubin says when we are applying pressure only on one aspect, whereas in Wood's corkscrew we are applying on both the shoulders, the pressure is applied, and we are trying to rotate it by 180 degrees. That is Wood's corkscrew. That is the difference. So you are trying to here bring the shoulder in oblique diameter, whereas here you are trying to bring the shoulder in transverse diameter, since they are longer in the inlet. So you are trying to deliver the shoulder this way. You get it? What is Rubin's and what is Wood's corkscrew? These are the internal maneuvers. Now, if they don't work, we have no other option. Finally, either break the clavicles. Once you break the clavicles using your hand, you can break. We call it clidotomy. So clidotomy is a procedure done in shoulder dystocia. So by doing clidotomy, this diameter will reduce. Okay. Third is last, if nothing is helping, by this time the baby might have got severe hypoxic injury. You have to deliver the baby within 5 minutes. So by this time 5 minutes have already passed. Now you have to deliver. You can't leave it inside. You push the baby inside and do a cesarean. That is your last resort. And when you do this, you already assume that we have lost the baby. Either baby is dead or either the severe injury has already happened. इसी कहते हैं Zavanelli maneuver. In Zavanelli procedure, you push the baby inside and you do the cesarean. All these maneuvers are called as internal maneuvers. Okay, so how we started? We called for help. Then we started with external maneuvers, which were, first we applied an axial traction. Then we went for suprapubic and macropods. Then if they didn't help, we went for internal maneuvers. Or Gaskin maneuver can also be done. It's a choice. In internal, first we try to sweep out this is posterior shoulder. You try to bring out the posterior shoulder. Then if it is not helping, you do the rotational maneuvers, which is Rubin's or Wood's corkscrew. Okay? If this doesn't help, break the clavicles, clidotomy, and finally Zavanelli procedure. Okay, you have to deliver the head within 5 minutes. Complications that will happen, obviously there will be a lot of complications in shoulder dystocia, some maternal, some fetal. Maternal complications will be obviously related to so long delivery and tears. So there will be perineal tears, there will be PPH. But baby will suffer severe injuries. There will be significant neuromuscular injury. There will be fracture clavicle and humerus. You are trying to bring the hand out. It can cause fracture humerus. Then brachial plexus injury. Since you are trying, the head is hanging outside, shoulders are inside, brachial plexus injury is the most common injury. And finally, hypoxic injury. That all can happen in shoulder dystocia. Okay. If you want to remember the steps, I personally never like too much mnemonics. I think जहाँ पे common sense से हम याद कर सकते हैं, you should not go for mnemonics. Still, since a mnemonic exists, it is an already very famous mnemonic, helper. call for help, evaluate for episiotomy. You have not given episiotomy, you evaluate for episiotomy. And then legs. Legs matlab Mech Roberts. I told you Mech Roberts comes prior to the suprapubic pressure. You never give fundal pressure. Uterine fundus pe pressure is never given. It will result in uterine rupture. You never give that. Okay? Then next E is enter maneuvers. Enter means what I told you, internal maneuvers, isn't it? Internal maneuvers. So internal maneuvers means sweeping out the posterior shoulder. You sweep out the posterior shoulder. If this doesn't help, then you go for RR. I'll write here. R is rotational. We know there are two rotational, Rubin's 2 and Woodcock screw. And last R is rollover. Rollover of what? Of mother. Is it Gaskin maneuver? Yes. So by helper also you can remember the steps. Okay. So this is all about shoulder dystocia. If there is any doubt, please mention in the comment section.